Hello everyone, this is Dr. Khan, Executive Plastic Surgery. Welcome to another Facebook Live. It's a pleasure and honor to talk about breast implant illness and a warm welcome to all the new members to my private breast implant illness support group page. I take this time to basically answer any questions you may have, so please feel free on YouTube, TikTok, Instagram, or Facebook. Please go ahead and ask any questions you may have, and I'll be more than happy to answer any questions that I'm capable of. So very interesting clinic. Today I saw a patient, 39 years of age. She had implants, and just from the beginning of the month, it started to turn red and painful, and she had a grade, what is a 4 capsular contracture and extremely thin flaps to the point where the implant literally was going to rupture through the skin. And I just talked to her yesterday, Sunday, the day before, and I asked her to come on in. She's almost an hour and a half away. And you will see that all of a sudden, from nowhere, there was this change for the worse and pain, redness. She's having night sweats, no frank fevers. And this goes on to showing you everything is fine, overall speaking. And then all of a sudden, she has what is a infection that is starting to brew on the right side. And she said it started in the beginning of August when she was at this graduation party. And this goes on to showing you that the implants are not lifetime devices. And, you know, if I may, the black box warning that is present in this memoir over here, in this communication, as you will see, the breast implants, certain labeling recommendations to improve patient communication, guidance for industry, Food Drug Administration. This was basically issued September 29, 2020. If I go to the black box warning, you will see, not my words, these are the words. Breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. And guess what? Her time was unfortunately up. This is a young patient who is now in a lot of distress and a lot of pain, and who needs urgent surgical intervention. She needs to be done at the hospital, so she's not going to get sepsis, and she can get admitted, and infectious disease can come by, and she can be managed. Now, this is very, atypical, unusual, but things happen. You know, there was a patient, she had like a folliculitis, like an abscess, if you will, from a hair follicle that got secondarily infected. Another patient that had diabetes ended up having an infection because of the compromised blood supply that she had, given her multiple previous surgeries. And again, this is an infection indeed can occur. And this goes on to showing you that, this can indeed occur in a small subset of patients. Interestingly, in the same patient, the 39-year-old, the left side ruptured in 2018. So she had a deflated implant all these years. Another very interesting patient that came today, she was a second patient, and she had, this was a second consult for this patient that came to me for the second time. She had her first implant in '86, and then she had what was a rupture of the implant. And in 2010, when the implant was removed, the implant was indeed ruptured on the right side and also on the left. And then 2010, she had what was replacement of the implants, and lo and behold, the right implant was ruptured. And then 2019, she had a replacement, and she had free-floating silicone. One set of implant was done above, the second set was done below, and the third set was done below. And so she has what is a ruptured silicone implant from above. So there she has silicone granuloma. The silicone did leak into the periphery, and so I have to clean out not only the implant silicone that had spilled into the upper part of the chest as far as above the muscle, but below the muscle, that silicone that had spilled, and the residual capsules as well below, along with the implant below. She has what is a 745 cc implant on the right and 560 on the left. So a large volume of an implant on the right and also on the left. Residual capsules above, plus spilled silicone above and spilled silicone below, and so a lot of inflammation on this 62-year-old patient that I saw for the second time, and she's obviously hurting, and this goes on to showing you it could be anyone, and that the implants are not what are lifetime devices, and the patient had a lot of symptoms of what is breast implant illness. Another patient that I'm operating on, she came to me from Arizona. She had her implants, a saline initial set, and then she ended up getting what is silicone implants. And as soon as she got her silicone implants, her symptoms went through the roof. And this is what I call a stir-up phenomenon. The initial set of saline implants were overall fine. The symptoms were minimal. But when she got her second set of implants, lo and behold, her symptoms went haywire, and she had many symptoms, complaints of what is breast implant illness. And so she sought me out. She researched me for 2 years, and now here she is going to be getting her surgery tomorrow morning. The other thing I want to mention here is that, there was a recent paper that was published in, one of the journals, recognizing what is breast implant illness indeed exists. We know it exists. Look at every patient who complains and who has improved after explantation. We have, patients, quote unquote, and again, part of the black box warning, patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. So this is by definition what is acceptance by the FDA, by the medical community, by the FDA, by the manufacturer. This is the manufacturing advertisement right here. As you can see, it says Mentor. You will see Allergan as well. At the top, they're advertising the Mentor advertisement. At the bottom, the same black box warning. And so you will see the same verbiage. Patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune disease, and others. Individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution of symptoms when the implants are removed without replacement. So complete resolution of symptoms means cure. And I will be, the word is absolutely getting around. The patients are talking about it. The celebrities are talking about it. The primary care doctors are also talking about it. And this is eventually only going to basically be accepted as the truth. This is already published. So this should not come as a surprise that the community is accepting. And this goes on to showing you that how slow the process is for the Plastic Surgery Aesthetic Society and the other societies to acknowledge what is a real problem and a real entity. And that we know this from the 1990s and 80s, in 1992 when the implants were banned, that the same silicone toxicity reactivity is indeed very much occurring, and that this is essentially history repeating itself. This is, if you look at the studies that were done in the 80s that led to the ban in 1992, we have all this data. We have all the problems that the patients are mentioning that, are the similar complaints of what are the rheumatological joint problems, the dryness of the eyes, for example, the autoimmune problems that the patients are exhibiting. And so this is clearly consistent with just listening to the patients, and you will see the complaints. Eventually, remember, everyone will need to get their implants removed, be it the infection like this patient, be it the capsular contracture, be it a rupture, be it inflammation, fluid, the very rare chances of what is the lymphoma. You can have acute and chronic pain, malpositioning, and the many other problems that occur with the implants. Now, the other thing I want to mention here is if you go to these guidelines, you will see what is, on the top of this. And remember, this is a patient decision checklist example. And so they tell you, what are the problems of the breast implants? And I'm just going to read this off. So, risks of breast implant surgery: breast pain, skin on nipple areola sensitivity changes or loss, asymmetry, infection, swelling, scarring, fluid collections, hematoma, tissue death of the breast skin or nipple, which is necrosis, inability to breastfeed, complications of anesthesia, chronic pain, damage to surrounding tissue such as muscle, nerves, and blood vessels. And as you will see, that, you know, they want you, patient initials, that your surgeon discuss these risks. And that it says over here, the next one, my physician has discussed these risks and has provided me with the patient information booklet brochure, including the boxed warning that I read earlier, with information on the types of risks that are possible and expected rates of occurrence. And the other thing I want to mention here is, if you look at the top of this page, which is page 14, you will see that, not my words, again, these are the recommendations as published. Over here, you will see, I understand that silicone can migrate from my implant into nearby tissues, chest wall, lymph nodes under the arm, and organs, liver, lungs, where it may not be possible to remove. I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. So this alone would be a reason to not putting in implants. Mammography can also cause the breast implants to rupture or leak. So this weekend I talked to a patient. She refused to get a mammogram because her initial set of saline implants, the right one, ruptured a week after getting a mammogram. And so she's afraid to get mammograms because she had a replacement. And so they tell you over here, I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed to the implant shell of silicone gel-filled implants, even if the implant is intact and not ruptured or leaking. And so this goes on to showing you that, you know, this is indeed occurring from day one, like Dr. Henry Dykman is saying. A list of the components, chemicals, and heavy metal is available in the patient information booklet brochure. And if you go to that list, you will see what is listed here as the heavy metals present, which are the arsenic, barium, beryllium, cadmium, chromium, cobalt, copper, lead. And then you have magnesium, mercury, nickel, platinum, selenium, silver, tin, titanium, vanadium, and zinc. So this goes on to showing you that this is the gel bleed that's occurring, even if you have intact. Some more, some less. And when you have a ruptured implant, the chances of that occurring relatively more, because it's now the silicone shell implant does not have an integrity, and now more of it is able to diffuse. Now, sometimes the capsule that the body forms around the implant, the patient is able to contain the badness, if you will. But then you certainly indeed have what is microscopic spread to the lymph nodes, to the lungs, to the livers, as you saw, as mentioned in this FDA documented brochure and article. Now, I just want to also go ahead and mention, you know, some of these questions. Please feel free to ask any questions that you may have. One of the patients I talked to, she said that she went to another surgeon who said that she could go back to exercising a week after explant surgery. And I'll tell you, that is virtually impossible in my practice. So it takes approximately 6 weeks plus minus for a patient to recover. And if your surgeon is telling you that it's going to be 1 week's recovery time and that you're going to be able to work out, that means you did not get the right surgery. So in my hands, in my practice, and my practice is essentially dedicated to a removal of implants, saline, silicone, and residual capsules. I take approximately 4 hours. I remove the capsular tissue in a very meticulous, controlled, dedicated, honest, sincere way directly on top of the rib. If you go to the YouTube shorts, you will see that the capsule spread of the implant is over an extensive area of the rib from the medial to the lateral and superior, 2 finger breadths below the clavicle and inferior. And that has to be shown to be removed in a very precise way. This is the ultimate and the only proof that your surgeon did the surgery right. We hear about surgeries being done in 90 minutes. Fat grafting, a lift, and a supposed explant in 2.5 hours, virtually impossible. I myself take 4 hours just to doing an explant. And as you will see in the vast majority of my cases, most of the patients do not need the unnecessary lift operation. So between, number one, removal of the implant that's pulling, dragging the breast tissue down, that being gone. So the breast tissue in itself can now lifts up because there is no gravitational pull of the implant down. Number two, because of the recoil of the skin and the breast tissue, the skin retracts 10, 20, 30%, sometimes even up to 40% the younger the patient. And so now the recoil of the skin and the breast tissue, there is no need or indication for a formal lift. Number three, because of the implant itself, in some patients more and some patients less, there is a concavity effect of the implant sitting on top of the rib. And now that indentation occurs. Now over the next several months and years, you will see the ribs now expand outward, because this is how a normal chest rib cage looks like and feels like. And now that protuberance of the rib in itself will add aesthetics to the breast. Number four, the pseudo lift that I do, that's very important, where I remove the excess skin, horizontal incision only, an incision that hides right in the crease. And then when I put the internal sutures, that helps lift the breast tissue up, not only medially towards the midline, but up. So the distance from the sternal notch down to the nipple areola is certainly diminished. How much, I do not know. A lot is, so that, and now, so the pseudo lift, if you go to AI and type in the 𝐾𝐨 pseudo lift, you will see exactly what the description is, and hopefully you will be able to understand exactly what and how I'm doing. And I hope to have more videos, hopefully tomorrow and the day after that, where I show exactly what I'm talking about. Number five, the fluffing effect of the breast tissue. Now with the proximity of the implant in the vicinity of the breast tissue atrophies, diminishes, decreases. With the implant gone, now the breast tissue gets a chance to fluff up. And with the inflammation subsiding, and between number six, the working out the 5, 10, 15, 20% muscle mass that the patients add to their chest, you will see most of the patients do not need that unnecessary lift. So I took care of a patient, 70 years of age, 70, and she had an excellent plastic surgeon who did her case when she got her augmentation many years ago, and she clearly did not need drains, and she clearly did not need a lift. And you will see her or hear from her when she does the podcast and the Facebook Live, that these are the patients who truly are not candidates for a lift. Now, if I see someone in pre-op, I will be able to make out that the patient absolutely will need a lift. I have done lifts before along with an explant, but I do not want to cut around the nipple areola and down, especially if a patient does not need it. So I've taken care of a 750 cc implant removal from below the muscle from a nice patient from New York, 37 years of age, and she clearly 6 months or so later said she did not need that unnecessary lift, no unnecessary cutting around, up and down the nipple areola. I want you to go ahead and see what exactly does a lift operation, or a S-lift, J-lift, or a mastopexy operation entail, so you can see the intensity of the dissection around the nipple areola. So in majority of the cases where the implant is below the muscle, I do not touch the breast tissue above the muscle. Even when the implants are above the muscle, I do not touch the breast tissue. I do not want to distort the self-monthly breast exam that the patient detects for breast cancer. That is 1 out of 8 patients who will get breast cancer. And I do not make any cuts up and down and around, and I do not want to distort the mammogram that the patients will get, that may show calcifications, irregular scars, abnormalities that may precipitate in more imaging or more anxiety, or maybe MRIs or even a biopsy. So very important not to do harm as the explant process is done. And remember, this operation is all about integrity, sincerity, and definitive certainty into removing the whole capsule, no matter how thin this is. Now, the other thing I want to mention here is there was a study done of almost 736 surgeons. We'll post this as well. And almost 70%, that's well over 2/3, stated that they are doing now more explants, that is total capsulectomy, this end block total capsulectomy. As you can see, there are a lot of surgeons now incorporating this within their practice. The point I want to make here is every surgeon is basically wanting to do it because there is more a trend towards explantation, and a lot of patients are wanting to explant. And now a lot of surgeons are claiming that they are what you would say are world-class or phenomenal explanters, or they have this technique down. In my mind, in my eyes, there's like a checklist of like 5 things, 6 things. Let's talk about those that kind of ensure, that kind of gives you that confidence and gives you that reassurance that you're getting the right surgery. So number 1, your surgeon must be a believer of breast implant, unless to the point where he or she is not augmenting, because that tells you why would they do any harm. Unfortunately, in today's world and age, you have a lot of surgeons who claim to be only explanting, but within their own practice, within their own roof, they have another surgeon who gets all the calls, who's doing only the augmentation. So you want to be very careful, because it dilutes that sincerity. Why would and how would someone say that the earth is round, but at the same time say it's flat, and just capitalizing on the explant patient? So this is extremely important. No one in the group under that LLC should be capitalizing and augmenting and at the same time dedicating one person to explant because they can market that person better. Extremely important. So your surgeon should be actively talking about it. Your surgeon should have a Facebook page where his previous or her previous patients must be actively talking about it. I will tell you, the patients are super smart. They know what's going on. They know when the surgeon is doing it right and when they're not doing it right. And there's a check and balance, and the patients are all talking to one another, DMing and talking to each other. So this is very important, that the surgeon has to acknowledge, has to have a Facebook page, and that the previous patients are talking to one another. Number 2, the length of the incision is approximately the diameter of the implant. So a surgeon that's cutting through the nipple areola to do an en bloc or a total capsulectomy, that is impossible to do, or through a small incision, impossible to do. Another thing is where the whole explant is being done in 30 minutes, 36 minutes, like I saw the last week, 90 minutes, impossible. Even 2.5 hours to do an explant and fat grafting and a lift, impossible to do that fast. One of them is being compromised, and it is very likely the en bloc. So the length of time should be approximately plus minus 4 hours. Number 4, the high definition pictures, videos of the chest wall. I think if you ask me, this is probably the second most or the most important point. You have to ask your surgeon to show the high definition pictures and videos of the chest wall showing complete removal of the capsule. That's part A, and then part B on the table, cutting open of the capsule. And this should be done consistently. I find some surgeons that when the implant is above the muscle hard, they show that and they say, oh wow, I'm an expert. But when it comes to the other 5-7 cases which are harder, they do not show. This is the time that consistently from one patient to the next, you must demand this on the consent form, that I want to see high definition pictures and videos of the chest wall showing complete removal of the capsule and the raw rib, the periosteum being removed, the perichondrium being removed, the fascia of the intercostal muscle being removed, the fascia of the serratus anterior, fascia of the pectoralis minor, and the fascia of the pectoralis major inferiorly, all being removed, and a high definition video and pictures showing removal of the chest, the rib cage, and also cutting open of that on the table. Number 5, the implants have to be returned to the patient. Some surgeons kind of puncture the salient implants and remove or damage the implants on their way out. Number 6, the surgeon has to send the capsules off to pathology, because that is the ultimate proof that if this was a 500cc implant, at least the length of that capsule should be approximately plus minus 12 centimeters or so. Because if it's a small patch of capsule sent, that was the only capsule that was removed, and that means that the capsule was inevitably left behind. So if you can do these 6 tests and check each one of these boxes, you can certainly sleep better, and you can have a very tranquil post-op period where you have the confidence that your surgeon is doing the surgery right. Now remember, when the surgery is being done, it is not about the speed. It's more about accuracy, pinpoint precision, and very much the surgeon's technical ability. So there's 2 parts to it. Number 1, the surgeon first has to believe in her mind or his mind that they're going to get the whole thing out in what is en bloc fashion or 100% total capsulectomy. En bloc is an oncologic cancer term, but the whole point here is that the whole thing is contained such that if there's a rupture of fluid or anything on the inside, it is all brought out as one system without a break in the capsule. So if it's ruptured, nothing's going to spill out. And so the surgeon has to believe that that needs to be done in every case. Last week I did a case on a nice patient, and to my surprise, the left one was ruptured. And this is where I did not know, but I went in assuming that it was ruptured, and it has to be all contained, and it has to be done in a very calculated, sophisticated way. And the second thing is that the surgeon must be able to do the surgery, because there are many surgeons who want to. They call me, they write to me, email me, they say, how do you do it? And this is something that they physically, I will tell you, have to be feeling comfortable doing it. This is an involved surgery because it is directly on top of the rib. But remember, in my practice, I give the patients the best shot. If it is ruptured, I'm not going to find out by cutting the capsule if it is or not. It should be on the table and not on the patient's chest. So the surgeon has to be very firm on removing it in a very calculated way, such that the last part of the surgery is where the capsule is tightly adherent to the rib. And that is, even though the trickiest part, it is done such that no fluid, no silicone spills into the chest, no capsule is left behind, and that the capsule is physically removed, not cauterized. In my practice, I find that a horizontal incision is the best and the only incision. That means it's going to hide right in the crease. I find that an up and down incision will not allow for optimal dissection in a horizontal plane parallel to the rib, all the way medial to the level of the sternum, to the level of the lateral rib, and from below the clavicle and all the way down. In my practice, as you will see, I noticed that the implants are all bottoming downward and outward. And initially when the implants were, they were much further up in the chest. So the capsule has to be removed with definitive certainty all the way up, and not to disregard that because it's hard or it is much further up or it's more tedious. And this is where the surgeon's commitment and honesty and integrity comes into play. You know, one of the things, if you can show me like a marker, you know, I mentioned this one point, it's up there, Sharpie up there. So if you look at, for example, you can give me that piece of paper right there. Yeah. So if you have, for example, you know, this is the capsule, for example, right? And just to use this, and these are the ribs, for example. The dissection is done very carefully, millimeter by millimeter, such that the entire globe, if you will, the implant and the capsule is very meticulously, carefully removed, such that the whole dissection is done with care and precision and integrity and honesty and professionalism. This is not a speed operation, and you are dissecting millimeter by millimeter, such that you're not going into the capsule, God forbid if it's ruptured, and you're going at, I use the word snail's pace, but very effectively and very efficiently. This is a surgery that's not about speed. This is a surgery about precision. You know, I just want to go ahead and mention, this is how it takes, and this is why once I came out after 6.5 hours, once I came out after 3 hours, because it was an easier case above the muscle, the capsule was thick, so it was an easier case, and the patient has the high definition pictures of the chest wall, above the muscle, easy, even high definition pictures on the table cutting open. So the patient has the peace of mind that there is no questioning the fact that was it even removed or not. And this is that utmost, absolute, sincere commitment. Now, I just want to go ahead and mention, I have heard this from almost a year ago, and this is a very important point I just want to mention. I heard about this just last week. There are patients of mine who are approached by other patient advocates who claim to be advocates, who want to be advocates, but in reality are advocates for another surgeon, and who approach, DM, talk to my patients, and unfortunately instill in them, well, you don't have to be a microsurgeon to do this. I will tell you, this requires the sophistication and the delicate surgery directly on top of the rib, in between the rib, and the microsurgical technique and instrumentation and handling with the loop magnifying glasses certainly comes into play. Now, I'm not reconnecting a nerve, obviously, on the chest, but this technique, this underlying sophisticated, delicate dissection, very intricate, needs to be done in a manner such that, you know, the microsurgical skills certainly come into play. This advocate has no concept of medicine. She is not even an RN or a medical assistant. This advocate is personally calling my patients who are driving to me to get the surgery and telling and instilling in them that the anesthesia is dangerous. She has no idea what even are the meds. And she is taking it upon her to basically instill suspicion on my patients. Now, my patients are smarter and better, and they understand how I do it, why I do it, because I talk to them. They have researched me, they have networked with me, and they know my previous patients. They have seen my videos. So I say this to my patients who are listening, please be careful. You know, unfortunately, this is not a professional world. It is unethical. It is illegal. It is unprofessional to do what you're doing. So those advocates who are out there, who are paid by the surgeons, who are taking, and I know their names, and we have the feedback, and we have the information, and we have the proof. I just want to go ahead and share this with you, advocates, and I know you're on my Facebook page. Please do not do this, because I'm not going to sit still, and I'm not going to accept this. And it is something that is not right, because you cannot take advantage of the patients. The patients understand what they're signing up for with me. I would recommend that you, as an advocate, go back to medical school, become a surgeon, and then you can talk about how to do the surgery and what is your technique, and then you basically can talk, and basically in a very professional way. The patients that come to me have the informed consent. They know what they're signing up for. So one of the patients that came today, she was my second patient in the clinic. I told her, I may never see you again. This is all up to you, whatever you want. She wanted to get an explant, but she did not want to lose the volume. I said, unfortunately, that is physically not possible. So you have to choose one or the other. And I told her, these are the choices in my practice. And if she wants to proceed with the surgery, this is what I would recommend. If she wants to, she can certainly keep her implants. Very similar to, there was a 46-year-old patient. She reached me. She had an MRI documented rupture of her left breast implant. And she reached out to me and she said, what would you recommend, doc? And I said, absolutely, you have a ruptured implant. It's a no-brainer. I would recommend removing it such that the entire implant capsule is removed as one system without any of the silicone spilling into the chest. And this is exactly what is basically not only the FDA, but the manufacturers themselves tell you. Get an MRI at year 3 and then every 2 years to look for a silent rupture. And that if you do have a rupture, that's why they're telling you to get the MRI, so you can get the implant removed. You don't want any of the silicone to spill into the chest, because no matter how much the silicone spills into the chest, this is an important point that one of my patients brought up. Once the silicone spills into the chest, you cannot wash it, irrigate it. You cannot use an antibiotic irrigation and clean it out, if you will. You will see these patients inevitably end up needing drains to kind of get rid of the toxins. And no matter what, how long you have the drains for, like 2 weeks, 3 weeks, they will continue to linger on, because that silicone has embedded within the soft tissues, and it will continue to linger on, and it will it is not healthy or smart to have silicone spill into the chest. There is a certain etiquette, at least in my practice, of removing the implant such that when done in the end block fashion, 100% total capsulectomy, the badness is not spilled into the chest. All of the badness is removed, that is the implant capsule and all of the inflamed tissue, and that there is complete sincerity in removing all of that inflamed tissue in the manner as described. This is why in my practice, the drain usage is not there. The last time I used a drain was well over 5.5 years ago. The burden lies on all those other surgeons who are using drains, because I even presented a couple of years ago at an international plastic surgery conference, my 1,000 explants, and I said, I did so many of these and I placed drains in only 7 of my patients. And the many ruptured 800cc, 600cc implants with fluid around inflammation, I removed everything in a very delicate, defined way, as you see on the Facebook Lives and the YouTube Shorts. And the need for the drain indeed is not there. The vast majority of the patients, 99.7% of them, they have less than 5 cc's of blood cell on each side, so a total of 10 cc's, and vast majority, well over 99.7. The need for the drain is not there because all the capsule is removed, no silicone spills into the chest, and that there's complete sincerity into removal of that capsule. That means I incorporate the fascia of the pectoralis minor, serratus anterior, intercostal muscle, the perichondrium, periosteum, and that all of this is removed definitively, completely, sincerely. In this the case where it is below the muscle, or if it's above, the fascia of the pectoralis major is removed. So the need for the drain is not there. The drains themselves, just being foreign entities, can sometimes induce a little bit of fluid formation. Remember, if the bulb syringe at the end of the drain opens up, then you can contaminate with the non-sterile fluid into the chest. The tube in itself can go in and out. So the drains themselves, yes, are used routinely, regularly by doctors, by surgeons, by plastic surgeons. But in the world of explant surgery, I will say with definitive certainty, in my practice, the drain requirement is not there. And that in itself authenticates for you as a patient that the surgery was done right, because the drain requirement was not there. And as you will see, my patients are talking to one another. No one goes and says, well, he was an excellent surgeon, but the drain was placed by another surgeon. No. Only those patients who have chosen to move their arms, which is a small, minute fraction, or those patients who have not worn the compressions have unfortunately ended up into the trouble of needing what is fluid aspiration, which is like a seroma, and usually is done once in order to correct the underlying problem, or in some cases where just they wear the compression and now the fluid gets absorbed by the body. Now, please ask any questions, and I'll be more than happy to answer any questions. Mar, do we have any questions?
Can an MRI show if capsules were not removed in 2003?
So the MRI cannot pick up on residual capsules. Sometimes the capsules are very thick. In that case, yes, because this is a soft tissue mass that will be picked up. But in the vast majority of the cases where I have done patients where they had residual capsules and their surgeon said that they removed the whole capsule, the MRI was unremarkable, and the MRI even said that the residual capsules not seen, and the patients were sitting on the fence because they're not getting better and they want the surgery done, and lo and behold, they said, well, the only other option is do nothing or continue as they were doing for the many years. And in those patients that came to me for the residual capsulectomy, I did absolutely find what were residual capsules and residual inflamed tissue, and those patients certainly did improve. So to answer the question in short, MRI will not always, and majority of the times in my patients who have had residual capsules, will not pick up on the residual capsule. So if you look at those 6 criteria I mentioned up further up, that before that will be a good indicator. And certainly looking at the op note from the surgeon, what does the operative note did the surgeon state clearly? Unfortunately, if you ask me, I have said and read many operative reports where the surgeon said that the entire capsulectomy was done, complete capsulectomy, or sometimes they say capsulectomy was done. We do not know if this was partial or complete, but the patients are hurting. And I know by looking at their symptoms and looking at their post-op, pre-op, that these are patients with residual capsules because their surgery was in 90 minutes, or their surgeon still puts in implants and the patients have the similar hurt as if they had the implants. And what is even more interesting is this: the patients themselves know that the capsule was left behind because they did not improve completely, because they had partial improvement in their joint pain or partial improvement in their ringing in the ears, for example. And so they know. There was once a case where this one plastic surgeon, she said she removed the capsule, and the patient post-op, there's a nurse. She's very well read. She knows her body. Remember, the patients know their body the best, better than any other doc. And then she's not improving. She improved somewhat, and she's like, I can swear there's something left behind me. She goes to another surgeon who, lo and behold, does an exploration and finds what is residual capsule, and the muscle was not repaired as was mentioned. And she calls the surgeon out and says, how dare you? And there was clear high-definition pictures and videos showing residual capsules. And this is where the integrity of the surgeon comes into play.
I have more questions.
Yes, please.
Do you recommend the capsules be removed or a partial capsule?
So this is a very good question. Now, if you look at the literature that's out there, let's go ahead and look because this is, if you ask me, the most important question that anyone's going to ever ask. What about the capsules? The whole surgery is about the capsules. Anyone can remove implants. One patient went to a general surgeon in her town, I believe it was Kentucky, and her general surgeon removed the implants. But guess what? The capsules were left behind. This surgery is all about the capsules and the inflamed tissue about the capsules. So there's fatty tissue, inflamed tissue. So if you look at this same breast implant, certain labeling recommendations to improve patient communication, guidance for industry and Food and Drug Administration staff, issued September 29, 2020. You can Google this document. It says up here, page 13, now they want you to initialize. Remember, these are the discussions that the surgeon is having with the patient. So they're saying the surgeon discussed this. Systemic symptoms. I understand that some patients who have received breast implants have reported a variety of systemic symptoms, symptoms including joint pain, fatigue, rash, memory loss, brain fog, that some patients have called breast implant illness. While the causes of these symptoms are unclear, some patients have reported relief of these symptoms with removal of their implants and surrounding scar tissue capsule. However, not all patients may experience improvement in their symptoms. I also understand that some patients with breast implants have reported health problems in their children after birth or breastfeeding. Now, let's go ahead and go to this top one. So they're telling you with removal of the implants and surrounding scar tissue capsule. So they're telling you removal of the scar tissue capsule. In another part of the black box warning, they will tell you removal of the implant alone, not the capsule. Now we know, look at the question before, those patients that have had partial capsule removal or no capsule removal, all the inflamed tissue removed, left behind, or the surgeon was rushing through the surgery and did not believe in removal of the capsule, these patients did not improve completely, definitively, wholeheartedly, all the way through. They improved 50%, 30%. Some patients even report they feel like they still have the implants. Obviously, they had their explant. So now these patients are saying, now what? Now, as I read, these patients now are doing their investigative work and realizing, like that patient from Germany, the many other patients that I've operated on with residual capsules, they're sitting on the fence, should I go for surgery or not? They have three options. Option number one, do nothing, pray to God, and hope that they're going to get better with time. Option number two, do a residual capsulectomy and exploration capsulectomy and removal of the inflamed tissue about. Or number three, they take immunosuppressive medications like prednisone, or like one patient was on Celcept, or the medications that are like Motrin to suppress the immune system or contain the signs, symptoms of what is suggestive of what is the breast implant, unless to control or to basically put a band-aid on the problem. Now, if you ask me as a plastic surgeon, if you look at the pathology report, you will see. Now, if you can, Mars, show me the pathology reports. If you look at the pathology reports, these are the reports of my patients. I've crossed their names out, and I'm going to read. Now, I get pathology on all my patients, 100% of my patients. Look at this one, left breast implant capsule. So this is the capsule around that I always send to rule out the BILCL. It says over here, the third line, refractile material associated with foreign body giant cell reaction and refractile material associated. And on the next page, it says that these are suggestive of breast implant particles. And if you will, over here, refractile foreign material is identified which may represent breast implant particles. There is no evidence of carcinoma or lymphoma. CD30 does not identify large atypical cells. So now the point here is, do you want to leave those breast implant particles, the silica, behind now that will continue to trigger the immune system, the body, and tax it? Absolutely not. And so I say to the patients, I say to the plastic surgeons, to the primary care doctors, to the plastic surgeon society president that I talk to, you want to put the best foot forward. You want to put the best course for the surgery so that you do it once, you do it right, you do it definitively, you do it with definitive certainty, you do it with integrity, you do it with honesty, and that you get the whole thing out once, the right time. Because what if the implant is ruptured? Now you're going to let silicone spill into the chest, so you did not do a total capsulectomy, correct? Or there's fluid around the implant, and now 3 of my patients had CD30 positive in the last year and a half. Those patients did not have to come back to me to do a completion capsulectomy because it was done right to begin with. A few of my patients, 10 plus minus, had fungal infections, candida infections. Their badness was already removed completely. So there is no residual disease or problem remaining behind. 3 of my patients had breast cancer. These were cancer patients, and they had breast cancer diagnosed in the capsular tissue. They did not have to come back to me. I told them my job is done. Look at the high definition pictures and videos. So I put the best foot forward. I do it right. Peace of mind, tranquility. Let's say if the implant is ruptured, I'm not going to go in and say, oh, let me try to see if it's not ruptured. I took my chance. No, what if it's ruptured and now the silicone spills into the chest, or there's fluid around the implant? I don't want it to bathe and basically spill over to the rest of the chest underneath the muscle directly on top of the rib. Do it right, do it once, do it definitively. So in my practice, it is a very positive, I don't want to use the word overkill, but a complete approach, and done very safely, done very definitively, done with the integrity and honesty, and done with utmost respect to the patient, so that once the patient gets done, she has all smiles, she's all smiles, and she has the peace of mind that she puts her head on the pillow that everything was removed and everything was tested, and so there is no second guessing, and then you have a complete recovery. Now, some of my patients have not improved because their silicone spilled into the chest, into their lymph nodes, maybe into the other parts of the body, as you heard, the gel bleed that I talked about earlier. Now, no matter how much you remove the implant and there's silica inside the lymph nodes and the periphery and the spleen or in the liver, like this earlier, on page 13 that I read, page 14, excuse me. It says over here, I understand that silicone can migrate from my implants into nearby tissues, chest wall, lymph nodes under the arm, and organs, liver, lungs, where it may not be possible to remove. So removal of the implant and the capsule and the inflamed tissue might not be the answer for these because it has already spread significantly elsewhere into the chest wall. I'm not going to remove the chest wall. I'm not going to remove the lymph nodes. And so these patients, unfortunately, are doomed and hurt. And, the underlying people to blame are the people who are allowed for the implants to occur and who are still allowing for implants to be placed very innocently, naively in patients. Remember, it's a big deal. The other thing I want to mention here is that the entire implant and capsule is removed, and the inflamed tissue around the capsule is also removed. So I have removed fat necrosis in some patients, what is a fibroadenoma, which is the most benign. The lipoma is also being removed. I've removed a fibroadenoma and a mass that was noted. Anything irregular, abnormal, I removed. Anything inflamed. If I'm sitting on the fence, should I remove or not? I remove, because I don't want to give it a chance, because it feels abnormal, palpates abnormal, looks abnormal. My sixth sense says abnormal, and I can tell when the tissue is good or not good. I remove it, because I don't want to say, oh, I wish I had removed it, and now the patient is not benefiting from the explant because the surgeon was a little bit timid about removing the bad tissue. No, it has to be removed because this is bad tissue. And so the inflamed tissue has been removed. I saw once on a Facebook page another Facebook owner saying and commenting on my explant where I had removed the implant and the capsule and the inflamed tissue about where that silicone had spilled into, right? Remember the gel bleed? It had spilled into the site, especially when it's a ruptured implant or a silicone gel bleed. And so I removed that tissue, and she commented, and the patient had, this Facebook group owner has no concept of medicine. She's not even in the medical field, not even a medical assist, not even a medical receptionist, who cannot comment on anything, probably does not even know how to read or write. And she said, well, I'm removing more tissue than she would like. And I said, who are you to make that decision? That inflamed tissue has come back as, you know, as you will see, look at this. You know, soft tissue changes compatible with implant capsule. You will see patients that their capsule shows what are foamy macrophages, clusters of foamy macrophages, focal giant crystalline material consistent with silicon with associated giant cell reaction. Focal synovial metaplasia. So this is the inflamed tissue in the periphery of the capsule that must and also be removed, because this is that whole cure and finesse, because you're giving the patient the best chance to bounce back. Yes, this is precious volume, but remember, I'm always below the muscle. I'm going to say this again. I'm always below the muscle. I am not touching the breast tissue above the muscle. I have not touched the breast tissue above the muscle in any of my patients. That's why I do not like to cut around the nipple. I don't like to cut up and down. I only make a horizontal incision. That certainly hurts my neck and back as I operate, because I'm operating at an angle. But I'm always below the muscle. I dare not touch the breast tissue above, because I don't want to change the self-monthly breast exam, or neither do I want to change or alter the mammogram where you're cutting up and down, or allow for pins and needle sensation around the nipple, or distortion or scar tissue up and down. And I do not want to hurt the anatomy of the breast tissue. So the next question I see, do you remove all inflamed tissue? So there is your answer. The doctor said would not touch irregular inflammation, because that inflammation results with the removal of the capsule. Now, this is a good point. Now, how do you know this is not the gel bleed? And how do you know this is not the silicone that has spilled? How do you know that's not the foamy macrophages? Now, grossly, when I see inflammation, I can tell this is good, healthy, fatty tissue. This is bad, hard, irregular tissue. So there is a fine point between good, healthy tissue and bad tissue. Ultimately, the microscope will tell what is what. But when I feel something that looks abnormal, palpates abnormal, the color is not right, and my gut tells this is inflamed tissue, I remove it, because I want to give the best tissue. And remember, below the muscle, the pectoralis major muscle is pec minor, which I do not touch. And then you have the ribs. So there is no extra inflamed tissue other than what is bad. So I'm not removing precious volume. I'm not removing breast tissue. I'm not doing, I'm not touching the breast tissue. I'm only removing the inflamed, bad, irregular tissue that needs to be removed, because this is the part of the recovery. So what do you use to clean the inside of the chest after you remove all? Antibiotic? So I will tell you, this is the implant is there. There is the capsule, and then there is that tissue. If there is a rim of tissue, you will see the capsules, the majority of which that are removed are relatively very thin. Now, as you will see, there is no frank infection, right? And so you do not need an antibiotic irrigation to clean the chest out. How many? So fact, so far to date, I have had only 2 questionable infections. 2 questionable infections in the many thousands of patients that I've done. Now, you would think that I give antibiotics to my patients right before surgery, which is the prophylactic antibiotics, which every surgeon gives. And then for a 7-day course, because there is a biofilm that forms around the implant and the capsule. So this is very commonly studied to be the Propionibacterium echinis and other colonizations with other bacteria. So in order to prevent any potential infection, now remember, with the implant, the foreign body and the capsule is out, the need for the antibiotic irrigation is absolutely not there, and I have not done it. I do not do it, and it's not required, period. If anything spills into the chest, or there is incomplete removal of the capsule and there is continued inflammation, then you will see the surgeons doing it. And I will tell you, in my practice, I do not do it. It's not required, and there is no indication for me to doing it. And because I've removed the badness to begin with, there is no indication for doing an antibiotic irrigation. What happens when the implant is above the muscle? So that is a very good scenario for me and the patient, because the muscle was not cut. The patient is going to have a faster, smoother recovery. Now remember, when the implant is above the muscle, that's certainly easier dissection, but the loss of volume is much noticeable. And normally when it is above the muscle, the skin is what's stretched out. And so the skin thins, attenuates, stretches out, thins out. And so it is a smoother, better recovery. Over time, you will see that the patient is going to improve relatively sooner, faster than having the dissection what is below the muscle. So I do not remove breast tissue at all. Let me say this again. I do not remove breast tissue, inflamed tissue. I do not do a partial mastectomy or lumpectomy or anything like that. There was once a case that I did where the patient had implant above the muscle. Implant was ruptured, and it literally had extravasated and extra capsular rupture, and it was flowing into the proximity of the breast tissue, and the patient had breast mastitis to the point where the silicone had made it almost to the skin level. Now I'm following that hard mass, the silicone granuloma, and that inflamed, hard, irregular tissue. And I have to remove, I'm obligated in removing the silica granuloma. I'm obligated in removing the tissue that's touching the breast tissue, and I'm not dare at all removing the breast tissue, because that is good, healthy, precious volume. I do not want to distort the breast tissue. But in this case, where there was spillage of the silicone into the breast tissue and the parenchyma, and now the breast tissue was bathed chronically with this old ruptured silicone above the muscle, that tissue inevitably had to be removed. And that is certainly the goal of the surgery, to remove all bad, inflamed, silicone infested tissue, leaving behind all good, healthy, viable tissue, that is the breast tissue in this case. So next question, please.
Is there anything I can do for pain from lymphedema?
So remember, you do not need a lymphatic massage after an explant. Lymphedema is meant for those patients that have had lymph nodes removed and now the arm swells. They have to go to a lymphedema clinic, usually at a place like University of Michigan, and when they do the lymphatic massage, the pressure garments that you wear, and they literally squeeze and push back. They have machines that you can bring home, and that will help with the edema. So please ask me the question again.
Is there anything I can do for pain from lymphedema?
So you have to go to a lymphedema clinic, go to their center. There are nurses that are lymphedema nurses. They have to have machines, whatnot else, that milk it back, physically massage it back, elevation, chronic compression. And these are patients who have had lymph nodes removed and now the arm swells up. You cannot get blood pressure, lab draws in these patients because of the breast cancer, the lymph nodes were removed and now the lymph backs up into the arm. So you have to go to a lymphedema clinic, and your breast center can certainly help you with that.
Okay, next question. I am 2 weeks post-op and now my back hurts and I'm not walking. Is this my body detoxing?
So what happens is, as you will see, almost all the patients have, because of the implants on their chest, they're leaning forward. The weight of the implant is kind of making their neck and back straight. Now with the implants gone, and if this patient has a contracture or chronic inflammation, now their posture is going to change for the better. So by default, their neck back issues may get worsened, or they might be improving for the better. And this is what I tell the patients: hang in there. And then as you gently work out 6, 8, 10 weeks later, and you do the neck, back, shoulder exercises, you're going to build all the core neck, back, shoulder muscles, and your neck back issues are certainly going to improve for the better. With the inflammation gone, the fibromyalgia type symptoms gone, the weight of the implant gone, the inflammation that spread as a result of the implants gone, the patients only inevitably improve. And it's not uncommon that the patients complain of back pain because now their posture is improved, now that they are not carrying the implants and the inflammation on their chest. So I tell the patients that you can be positional, and with the exercise, most of the patients ultimately do improve.
Will you do a lift at the same time is the Explant?
So I answered this question earlier. You know, the between the fluffing effect with the implant gone and now something not pressing against the breast tissue gets the fluff out. Between the concavity that the implant may cause, sometimes less, sometimes more, sometimes not at all. The rib cage is going to protrude out. That will help with the shape of the chest rib. Between the working out 10, 5, 15, 20% muscle mass you add to your chest, the pec major, pec minor, latissimus serratus, you will add aesthetics. Between the recoil of the skin, that 10, 20, 30% of the skin that recoils, between the pseudo lift, between the sutures that I put that lift the breast tissue up, you will see there will be a good recoil of the breast tissue as a result of me not only going medially but upward. Between the implant that's gone, that's dragging the breast tissue, that's gravitating the breast tissue down, that gone, the breast tissue in itself is going to recoil. And between the inflammation subsiding and now it's not going to be as tonic, the breast tissue will be now less inflamed and less droopy. And all of this, if done by a good plastic surgeon who knew what they were doing when they were augmenting, who did not cut the muscle much, and who are very smart and astute by not placing large implants, you will see most of the patients do not need that unnecessary lift, to the point where I have said 80% of the patients. I have a patient 70 years of age, as I mentioned, and many 60-year-olds, 50 years old who have 300, 400, 500 cc implants who truly did not need a lift for the above reasons.
Is saline safer than silicone?
So both of them are bad. It is just like saying a cigarette is safer than the cigar, or this cigarette has a filter, it is a better because there's less nicotine going to the body. All of them are equally bad. And when they banned the silicone implants in 1992, they should absolutely have banned the saline implants. And hopefully when the ban comes around this time, they should hopefully ban the saline implants along with the silicone implants. And they are, so if I see 1,000 patients that come to my clinic, I cannot tell by their symptoms, oh, you have saline or you have silicone. They have the same set of problems, the suicidal ideations, the neck, back, joint pain problems, all the problems, the ruptures, the whatnot. Else look at the patient that came in today, the 39-year-old with the infected saline implants. Remember, they cause the same problems and hurt as silicone, and the problems are interchangeable, both bad.
Will removal of my implants resolve my autoimmune disease?
So guess what over here? I'm going to read not my words. Anything what I've said are not my words. Patients receiving breast implants have reported this is the black box warning. You can Google this. Black box warning, breast implants. Patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune disease, and others. Individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution of symptoms when the implants are removed without replacement. Complete resolution means cure. So autoimmune problems. So you will see a lot of patients have autoimmune problems from Raynaud's to like God knows Crohn's, ulcerative. Now, it's not that the implants cause these patients to have this, but the autoimmune problems are lessened, decreased. There was the study done that showed the patients who had implants, they had higher chance for Sjogren's, rheumatoid arthritis, scleroderma, and there's a clear association between the rheumatological joint problems and the implants. So autoimmune problems are a big part of what is breast implant illness. Now, what we do not know. A lot of ladies get autoimmune problems more so than men. So the autoimmune problems are diminished, decreased, lessened, less severe, even than 20-30%. Now, I do not know what type of improvement someone will have. So the patient who had bad psoriatic arthritis and psoriasis, her symptoms improved dramatically. The other patient who had resolution of her 20-30% of the joint problems and she had underlying rheumatoid arthritis, that was the relief. This weekend, I talked to a patient with Crohn's disease. She got it at age 15. She should not have gotten breast implants, be it saline or silicone, period. These patients, it's a contraindication. Some patients, transplant patient, cannot get breast implants. Patients with immune compromised state, like diabetes, vascular compromise, they should not get implants. Patient who has underlying rheumatoid arthritis. This one patient had juvenile rheumatoid arthritis. She got it at age 5. She is not a candidate for implants because of the underlying autoimmune issues that the patient has. You do not want to compound her picture. Remember, the implants only ultimately hurt the body. No one walks into my clinic and says my implants are making them run faster, think sharper, or they have more energy, their joint is improved, their neck back pain is better, their vision is improved. Now they got rid of glasses, their hair is more thick, their ear is sharper, they can see better, or they don't have the throat trickle, they don't have autoimmune problems, they don't have GI disturbances, they don't have all problems after problem after problem. Not all, but you will see that eventually all bad sooner or later. Breast implants are not lifetime devices. That in itself tells you, plus minus 10 years, not worth the pain and the misery. So the next question is, what imaging do you recommend for elegant, smooth saline under the muscle? Now remember, saline implants are, when they do rupture, they rupture completely like an empty IV bag. So this 39-year-old patient who had a rupture in 18, she said all of a sudden deflated. That's the saline implant. It will rarely partially deflate and kind of seal itself off. I've seen only one case. So when they do rupture, it's like an all or none response. The silicone implants, you could poke it with a needle. It's still ruptured, but you will see it's disintegrated. It's very gooey and it's slimy and all that. And there is nothing cohesive. And it will still retain its shape. And that's why they say getting an MRI for silicone implants at year 3, and then every 2 years they're onward. So if you look at, for silicone implants, MRI. Saline implants, just a good exam is good enough. Not my words, words of a mentor. Quote, MRI screenings are recommended 3 years after initial implant surgery, and then every 2 years after to detect silent rupture. Quote unquote. Silent rupture means that the exam is excellent. Patient goes in for an MRI and it shows a rupture, and you would think the patient at least would be in pain or distress or capsular contracture. No, it's an unremarkable exam. And they're telling you get an MRI at year 3, and then every 2 years they're onward. The FDA stepped up and said get an ultrasound, but if the ultrasound is not good at 5 years, then get an MRI. The better answer is an MRI. Now, the next thing is, do you want to wait for a rupture and then pull the implant out, or do you want to do it preemptively? Do you want to take care of a small fire versus a big fire? Because remember, the implants do indeed rupture. How many patients are going to follow the guidelines that the mentor is putting forth by getting a MRI at year 3 and then every 2 years they're onward? Less than 5%. If you look at Dr. Frank Lewis, who did this analysis and said this is something, you know, a CYA action, but in reality, no one's going to do.
Okay. What are the expected effects of using mesh?
So this is the mesh, Galaflex mesh that's used by the surgeons that forms a scaffold, disappears over the 6 months, 8 months, and now leaves scar tissue. Technically speaking, there's no mesh left behind because it disintegrates, and so that scar tissue is left behind. The whole goal here is removing the implant capsule and the inflamed tissue, leaving behind all good, healthy, viable tissue.
If I have capsular contracture, will getting smaller implants reduce the chance of it coming back?
So it's being studied. Majority of the times we do not know why capsular contracture occurs. Capsular contracture is where the implant is. So any foreign material in the human body, be it a pacemaker, be it a lap port, be it a hip implant, or a screw that was used to reconstruct the hand, or in this case, the implant, will form a scar tissue, in this case, the capsule around. That capsule basically is the body's response to what is something foreign. Now, ask me the question again, please, if you will.
I have capsular contracture. Will getting smaller implants reduce the chance
Right.
of coming back?
Now, once someone gets capsular contracture, chances are you will get capsular contracture very high again, because your body is kind of telling you, I'm rejecting it. And what's interesting is one side is pristine normal, the other side has capsular contracture. So you will see many patients who have gone in to get a capsulotomy where they score open the capsule. Now the capsular contracture inevitably forms again. So if studies have been done that have shown that if there is a biofilm contamination, capsular contracture occurs. If this is a larger implant, higher chance. Smaller implant, less chance. Implant above the muscle, higher chance. Below the muscle, lesser chance. But majority of the times we do not know. It is just pure coincidence. Everything is going well. 7 years later, out of the blue, the right side looks good. left side forms capsular contracture. And remember, capsular contracture is not normal. This is the body kind of walling off the badness, if you will, and there is something going on, maybe a fluid, maybe a reaction, maybe trauma, God knows what. And this is where you do not have to be living with the capsular contracture. Sometimes the capsular contracture can form like a hard ball. So the small implant, statistically and theoretically less chance, but that chance still does exist. If the capsular contracture occurs, I say chances are higher than not, or very likely that you're going to end up capsular contracture again, even though this is a small implant, but time will tell and no one can predict. Yep.
What should I look for in a surgeon?
So remember, the first and foremost thing is listen to the surgeon, listen to their Facebook post, listen to the surgeon's previous patients, not one or two, not the advocate. I will tell you, I have had 10 people reach out to me and said, I will vouch for you, you pay me, and I will send you patients. I have had, and I'll bring this forth, I'll find it. I got a text from a patient that said, if you utilize me, I guarantee you 3-5 patients. Another text, another Facebook group owner said, if you pay me a contribution for BII support to help the many ladies, again, this is a bribe off the record and directly, if you will, I will send you, I have literally these many thousand patients on my Facebook page, and I will promote you, and I'll put an asterisk, and you will get. I said, shame on you for suggesting that, and I'm not going to take that bait, and I'm not going to have people who are going to sell their soul to the devil, take advantage of another patient's misery, and pocket money by referring patients to a surgeon claiming that they're world expert. That, in the world that we're living in, is rampant and everywhere, unfortunately. There's another one who's like, I wrote a book, I will promote you. I'm going on one Facebook page to another, I will promote. I said, you know what, I'm going to do my own promotion. I'm going to talk about it. I don't need anyone. I want my patients to talk about me. And if you ask me, the patients are super intelligent. They know, they can read minds. Almost, I would say, a good fraction of my patients, they know me for a year or two. The patient that came to me from Arizona, she knows me for 2 years. She's researched me, networked me. Don't rush into the surgery. Learn what the surgeon wants to do, why he wants to do, what is the social media feedback, impression, patient's sixth sense feel, the reviews, the integrity, the professionalism. There are surgeons who are excellent in deleting Google reviews. There are surgeons who are excellent in promoting themselves on Real Self. There are surgeons who know how to market themselves and by doing the right press releases. There are surgeons who are like within them, they do not even believe in what is breast implant. They have reached out to me. Some of them, believe it or not, are my acquaintance friends at a meeting that said, can you show me how to do it? And I asked them, do you believe in breast implant illness? And they're like, hell no. This is what we're unfortunately dealing with. And now majority of the surgeons are doing explants, and they're doing it literally on the job training. So you have to look for the integrity, and you can certainly sense it. You have to ask the patients, that the previous patients of that surgeon, as to how good he or she was. Did the surgeon show high definition pictures and videos? The surgeon should not be augmenting, should be only explanting. And the whole group, if you go to the surgeon's website, and you will see under the same web page, there's another surgeon who's augmenting, and the surgeon has augmentation pictures, or another surgeon within the same list of other surgeons. I promise you, that surgeon does not believe in breast implant illness, even though the impression or the illusion may be that they are. You want to go ahead and see that the surgeon is talking actively and promoting breast implant illness awareness. Remember, someone who is only explanting and not augmenting, it takes an hour or less to do an augmentation, and 4 hours plus minus to do a explant. And the time it takes, the difficulty of the surgery, the difficulty of dissection on top of the rib, versus putting them in. And these are two different operations. The mental, physical, the ability to discuss and to filter how much the surgeon is involved. There are many surgeons who don't even see their surgeon to their patients afterwards. Many patients know their surgeon did a hack job, sorry, quote unquote, because their surgery, they did not reproduce pictures, high definition videos. Some surgeons say that this is a HIPAA violation to show a chest wall picture. No, it's not. Patients get to see, and they absolutely have the right to see their chest wall high definition pictures and videos. If you show one patient, and she said do not show with the name and to another patient, that is a violation of HIPAA. Not to show her own pictures, that the patient should herself ask on the consent form, I must get pictures, high definition videos of the chest wall right and left consistently from one patient to the next. That is the integrity that you're looking for. That is the commitment that you're looking for. And you will know from your heart and your mind. And you know, you can always talk to the surgeon again. You want to make sure you're talking to the surgeon directly, not to their nurse practitioner or their medical receptionist or their nurse practitioner or their physician assistant or their hospital, the manager of the practice. You want to talk directly to the surgeon, and you want to have a bond, that integrity that one of my patients called me up and said, there's a typo on your new intake form and you please correct it. And I started, she's so firm, she knows that I would dare not even do something like this, and it was a clerical error, if you will. This is the type of commitment, the peace of mind you want to have, such that when you do sign up, you're only smiles.
I have another question.
So one quick question, how long will my incision in my 200cc implant? So the diameter of the implant is going to dictate the length of the incision.
How do you know if your implants are making you sick?
So this is a good question. So let me give you a perfect example. A patient I talked to over the weekend, young patient, 42. She said, I've been to the rheumatologist, endocrinologist, primary care physician. I have all the labs checked. I have done the imaging. Everything is normal. My doctor says I am A+ healthy and that it's the stress. I have joint pain, neck, back pain problems, brain fog. And then I look and I tell the patients it's a diagnosis of exclusion. So you go ahead and fill out the forms: brain fog, fatigue, muscle aches, pain, weakness, joint pain, soreness, easy bruising, weight gain, weight loss, dry skin, eyes, chest pain, suicidal ideation, depression, mood swings, anxiety, throat clearing, headaches, ringing in the ears, metallic taste in the mouth, gastrointestinal digestive issues, decline, change in the vision, thyroid, adrenal problems, autoimmune. So you check off. Now, this is what I asked one of the patients, and many patients that I've asked. If you look at the symptoms, here's almost all the check boxes, or half of the check boxes. The patient has normal labs and normal workup. I asked the patient, what % chance do you think you have breast implant? The patient's like 100%. I said, you bet 100%. Now, this is something, I'm not crazy because it's a diagnosis of exclusion. Now, this one patient that I talked to over the weekend, she's got rheumatoid arthritis. I told her, listen, you're postmenopause. That in itself kind of changes the body for the worse. The estrogen, progesterone is down. You have rheumatoid arthritis. How much is what? The joint pain, fatigue, the malaise, and the weight gain, and the GI issues, the side effects of the medications, whatnot else. And how much is the breast implant illness? I said, by definition, just the fact that you have rheumatoid arthritis alone is a reason to removing the implants. Case closed. Just the fact that your implants are over 10 years old is in itself alone a reason to remove the implants. And then post-op, with definitive certainty, when the whole capsular tissue is removed, then we will see in what capacity and how you're going to bounce back. I never guarantee or talk to anyone. I always say these are the signs, symptoms suggestive of what is breast implant illness, and now 90% of the patients or more say they feel better, this is better, their eyesight is better, their neck, back pain is better, they're able to tolerate pizza and ice cream, which before they could not. Their vision is better, their hair is not falling off, their migraines are better, chest pain, palpitations are improved. Not my words, the words of my patients, right? And this is where, if you listen to the patients, they know in their body what's the problem.
What is a gel bleed?
So gel bleed means this, where you have an implant you put in the body. So if you go and look at any of my YouTube lives and my Facebook live, I remove the capsule by cutting it open. And now as I touch the implant with my new glove, and then I see what is an intact silicone implant, intact saline implant. And so I've just touched the inside of the capsule and the implant. And now when I go like this and I go, you see the sliminess, the stickiness, the gel bleed. It's microscopic. It's slowly leaching of the silicone to the point where one of my patients from Nevada, she sent me her card and it said on the card, Siltex low gel bleed. Gel bleed is a phenomenon that is the leaching of the silicone into the periphery from the intact silicone implant, intact saline implant, and certainly a lot more involved if it's a ruptured silicone implant, because now the shell of the silicone implant is weak. And so this is the gel bleed phenomenon where the silicone is leaching. Imagine you throw a dye, a red dye into the pool, and now that red dye is spreading, diffusing into the periphery. That red dye diffusing, that's like the gel bleed. That's the leaching of the silicone, if you will, into the periphery. That means into the lymph nodes, into the sternum, not in all, but we have seen ultrasound MRIs done that show silica seen within the lymph nodes. You do a biopsy of the lymph node, you see silica within it. And this has been documented, not in all patients, in small subset of patients where the studies have been done. So Dr. Atul Mehta out of the Cleveland Clinic, he and I did a Facebook Live on one of his patients where he had shown, he did a lung biopsy of a patient who had ground glass opacities of the lung. So that's underneath the rib. And he did a biopsy of it and he sent that specimen to a lab in Buffalo, New York, and they did what are electron microscopy studies, and number 2, energy dispersive x-rays, and they showed it's silica. And the causative agent, the way the silicone made it to the lung is through the bloodstream, and it leached from the silicone shell of the saline implant. And this goes on to showing you that this is not an inert in the eyes of Dr. Henry Dykman, who's a true hero, who's done a lot of research, has shown that gel bleed occurs from day one, and I'll tell you that is indeed true. This is a known phenomenon. There is no discussion. This is a well-accepted entity.
Okay, next question. If there is no inflammation, will you remove the implants only?
So this is a good point. No. Remember, so this is again a very important point. So anytime any implant is placed into the body, now this is a big statement I'm making. Anytime any implant, be it saline or silicone, that's placed into the body, be it above the muscle or below, inflammation sets in. The body recognizes the implant as foreign. Now, sometimes or most of the time, the inflammation is contained, controlled, less, and it is acceptable, and the patient is not exhibiting. And these are the many patients, millions of which who have implants, and they say this is the best thing that ever happened to them, that they got their implants. Now remember, there will come a time, because remember they're not lifetime devices, where now the capsular contracture occurs, or the infection occurs, like in my patient today, or a biofilm forms, now a fluid forms, there is trauma, or there is rupture of the implant. Remember, now the inflammation becomes more, it's pronounced, or it gets out of hand, or the body's not able to contain it. And again, this is the phenomenon of what is suggestive and consistent with what is breast implant illness. So the inflammation occurs 100% of the time, to the point where there is a paper out of the Sloan Kettering, where they actually studied the capsules around the implants. And they show microscopically, I have it on my Facebook page from many years ago, where they looked at inflammation that sets in acutely and then chronically around, and this is within the capsular tissue, because remember that is reactive inflamed tissue that forms around the implant.
Next question.
So I always remove the capsule, because remember, in my practice, I want to give you the best shot. I don't want you to come back if you don't improve, because you cannot state you have no inflammation, because the inflammation is present, like I said, 100% of the time.
Will you remove implants below the muscle and do fat transfer above?
So fat transfer, I use the word malpractice idea. Some of the fat takes good, excellent. Some of the fat dies, the body absorbs it. Some of the fat, maybe 5, 10, 15, 20%, depending on the technique. the fat will form clumps of dead fat. It might take in some areas, not take, and now fat necrosis occurs, and now you feel irregular dead fat, painful, and now you might be like, is this breast cancer? Is this a breast mass? Is this a benign tissue? And now you're getting an ultrasound or a mammogram, or now maybe even an MRI or even a biopsy, or now it's kind of causing you anxiety. Remember, 1 out of 8 or 9 women are going to get breast cancer, and you want to be able to do a good self-monthly breast exam. That's the most common way of picking up on breast cancer, or a mammogram. And fat grafting to the face, I'd say excellent idea. To the breast, bad, malpractice. Oil cysts form, acute and chronic pain, not only at the donor site, but the recipient site as well. Asymmetry, fat necrosis, indentation, irregularities. I saw another post by another plastic surgeon who stated up to 60-70% of the fat may die. And I remember on the surgeon's technique, right? How much of the fat is being injected. Today I saw there was a patient that got 450 cc's of fat. I'll tell you, a lot of that is going to get absorbed and a small fraction is going to take, and now there are going to be some clumps of dead fat that may form. This is all dangerous because you're now compounding the self-monthly breast exam and a mammogram, and now breast cancer is being missed in the name of aesthetics. Bad malpractice medicine in my eyes.
How did I...
So I was at a conference, and the gentleman sitting right next to me was the chief of plastics at a major hospital of the world, where he was the major notable figure when it came to the breast augmentation, breast reconstruction, and advancements of medicine, and plastic surgeon, board certified, the real deal. I asked him, when you do fat transfer, what is your take? How do you discuss with your patients? And then he was a very nice professional. He was very nice, collegial, very, very good, very honorable man. I asked him, how do you have your discussion with your patients? Do you tell them, about the fat necrosis, that small possibility on the mammogram or the self-monthly breast exam? He said, I talk to them, I tell them, but they look good. And I say, yes, but looks good at the expense. And I'll tell you, if you ask me anecdotally from a lot of patients who have had fat transfer, they say it was not a lot of volume that they got. It was not worth the pain and misery. And if you ask me, it's not a benign. Now, I will tell you, if you're still interested in getting the fat transfer, I want you to really look into and see how much of the fat takes, how much of it forms, how much and what of it is going to be injected. How does the surgeon do it? Look at the risk versus benefits. So in my eyes, remember, I'm like as organic can get. I'm a minimalist. I don't like the risks at all. I'm never going to get a facelift in my life, and I can go to 10 of my friends who'll do it for free. That's just me. And I say do no harm. And I'll tell you, you're going to do harm. Last week I mentioned a 28-year-old getting breast cancer. Yes, breast cancer is 1 out of 8 and 9. Do not disregard that number. So if you have a stadium full of 100,000 patients, 10,000 in their lifetime will get breast cancer. So we do not want to compound screening for breast cancer, and fat grafting, I say, is a big no.
How do I find out the placement of my implants if my surgeon did not tell me? So
there's 3 ways of doing it. Number 1, you can go to the op note and get the op note, be it on a microfilm or an operative note that might be on the electronic medical record. Number 2, you get an MRI. That will tell you if it's above or below. Sometimes if the radiologist is good and smart, or you have a good ultrasonographer, they can tell if it's above or below the muscle. And third is when you're getting the explant, then you will see clearly that if it is above or below. Believe it or not, today, that one patient that came to me that had the 86 implant and then the 2010 and 2019, and she had the rupture above and below. So her last operative report from a major, quote, reputable surgeon done right here in town states that the surgeon placed the implant below the muscle, submuscular, and I'm reading and looking at the op note, and I told her to get an MRI because she has the ruptured silicone above and below to look for any of those silicone granulomas, silicone pockets. And so the op report says that the It's been 1.5 hours. I've been told I can talk forever. But as you will see, the surgeon wrote in his report, I read it with my own eyes, that the surgeon said that he placed the implant submuscular. I look at the MRI that was just done on 7/30/2025. It says the implant is above the muscle. Now, either radiologist read it wrong, or the surgeon who dictated it, or the assistant, whoever dictated it, is wrong. And this goes on to showing you, only when I do go in, that's when I'm going to find out what is ultimately the right placement. Any good, reputable, board-certified plastic surgeon, another way of putting it, if I see 1,000 patients who come to me in my clinic, 950 of them, or well over 900 of them, are going to have below the muscle. So any good, reputable, board-certified plastic surgeon will put the implants below the muscle, because that's better, less contracture, less infection, less problems, less issues, better long-term results. Let me correct that. Any good, reputable, board-certified plastic surgeon will not be augmenting, but will be truly, genuinely explanting. So that is what I will like to say in regards to what is the placement. All right, so these are very nice questions. You know, we'll do this again next week. If I have, you know, Monday afternoon, evening, we tend to do this. So please go ahead and get your questions ready. If I do not know the answer, I'll be the first person to say I do not know. We know quite a lot. We know quite a lot from the patients. That's the ultimate. The patients teach me, tell me, they talk about it. They tell me their symptoms that are on this. I'll end with this. All what I said is written in this, the mentor advertisement. Look, they're advertising this, and at the bottom is the black box warning and the warnings. You will see in the pathology report of my patients full. I have hundreds on my other desk that talk about, let me just spontaneously go to this one. Another pathology report. Right breast implant capsule. I just went in the middle. Fat necrosis, breast implant capsule. Fat refractile foreign material presents. Refractile foreign material identified which may represent breast implant particles. So this is where, if I see inflamed tissue, I'm removing it because I don't want to leave the dead fat behind. Neuroma, I've removed neuroma. So we have even this breast implant, certain labeling recommendations to improve patient communication, guidance for industry and Food and Drug Administration staff. This should be given to every patient. So the patients, as you will see, will initialize all the risks that exist. Patient initials. I understand that breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but some quantities have been found to diffuse gel bleed to the implant shell of the silicone gel fill implants, even if the implant is intact and not ruptured or leaking. A list of the components of chemicals and heavy metals is available in the patient information. I didn't write this. And this is the point I'm trying to make. We have enough information, ample knowledge. We have the right objective information. And most importantly, we have the patients who are hurting, complaining, and really, I use the word, in distress and looking desperately for answers. I urge RFK, I urge the plastic surgery societies in Europe, South America, and North America, Canada, US. I urge the rheumatological society. I urge the primary care, emergency room physicians. I encourage you to read on whatever I read. I didn't make this up. I wish this was done and closed. And I wish every major city in the United States offered Explant in the manner that where it's complete and thorough. I don't want to say overkill, but right and complete. And I wish that there was an ICD-10 code so that this one patient who came to me, he cannot afford it. She has the system who says that the implants were safe, pays for it, and that it is done in a complete, thorough manner. And I'll end with this. What is the con procedure? No need for the unnecessary drains. Majority of the patients do not need the unnecessary lift. The cultures are sent for microbiology, aerobic, anaerobic, and fungal. Capsules are sent to pathology to rule out that rare BIAL-CL CD30 analysis is done. Breast cancer is ruled out. The implants are returned to the patient. Twilight, deep sedation. high definition pictures and videos of the chest wall, and every patient, be it the 89-year-old, 22-year-old, the 55, the doctor I took care of today, the stay-at-home mom who's hurting, they all get the same surgery, so that when we look back, we can say we did the best for the patient. We did what we would do for the president, if you will, if she was our lady and she had implants, because everyone deserves the world-class care. Do no harm and do it correctly, right? Definitively, we have a lot of data with us. This is Dr. Khan. Take care. Till next time, all the very best.